Here's what we got to look at. Normal respiratory rate is what?
12,
20.
Heart rate,
60 to 100.
pulse ox,
96 to 100.
end-tidal CO2.
35 to 45.
All right. So if I had a question and the patient was having trouble breathing and it was this. All right, respiratory rate 24, heart rate's 112. Whoops. Sorry. Pulse ox 94%, end-tidal 50. What best oxygen delivery device would you consider? Nasal cannula. So you put them on a cannula. How would I know their ventilatory status, aka breathing, improved? And what else?
Heart rate.
So what I would want to see is respirations move back towards 20, heart rate to move back towards 100, pulse ox to increase, end-tidal to move back towards normal. So I'm wanting to take these parameters from outside the normal range and move them back towards it. If I put them on a cannula, let's say I put them on 4 liters, a couple minutes go by and they're now here. They getting better or worse? All right. So you had them on a cannula. What would you go to now? Okay, non-rebreather. So we put them on non-rebreather. Same rules. If they're getting better, respiratory rate should move back towards 20. Heart rate should move back towards 100. Pulse ox should move up and end-tidal down. What happens if I end up here? All right, somewhere between non-rebreather and positive pressure ventilation, aka BVM, you should consider CPAP. Somewhere between there. Can't go backwards. See this video. There is no set number on when you should be CPAP versus BVM. What we have to remember is that if they become altered or they start breathing too shallow, it is too late for CPAP. So somewhere between a non-rebreather not working and having to go to a BVM, we need to be putting them on CPAP. If we miss our window for CPAP, we can't go backwards. They have to be breathing at least 8 times a minute. They have to have a blood pressure of at least 90. They have to be alert oriented and follow commands, and they have to be breathing deep enough to break how many centimeters of water? 5 to 10. Initial settings 5, max of 10. So they have to have those things in place in order to use CPAP. There's not a number where I could say, hey, if somebody's breathing 30 times a minute, put them on CPAP. There's no exact number. It's going to depend on how the patient looks, on their age, how long they've been like that. If we were to give an exact number, that would be impossible. I bet some of y'all have been breathing 30 to 40 times a minute after working out, correct? Does that mean we go, hey, hold still, let me put you on CPAP? Maybe wish we had it, but that's not necessary. So it really does not have an exact number. I can make an argument that a 19-year-old breathing 40 times a minute can tolerate that longer than a 7-year-old, and we wouldn't necessarily have to put that 19-year-old on CPAP. But if that 19-year-old's been like that since 10 o'clock last night, we better do CPAP right now or we're going to miss our opportunity because he's already extremely tired. Does that kind of make sense? So that's what we're looking at when it comes to do they need CPAP or not. Somewhere between non-rebreather and having to ventilate them, we need to do CPAP. If we wait too long and they're altered, not breathing deep enough, not breathing fast enough, pressure gets below 90, we've missed that opportunity. Once we start bagging them, if they don't get any better or they stay the same and get worse, what do we have to do next?
Innovate.
Innovate or King 2. Those are both advanced airways. An advanced airway is not ventilation. What do I mean by that?
It's not causing chest rise and fall.
An advanced airway will not cause chest rise and fall. If I intubated somebody and just set the tube there, it's not going to make their chest rise and fall. You still have to use ventilation with it. You still have to attach it to some sort of BVM or manual trigger device. Intubating somebody is not ventilating them. Intubation is an advanced airway adjunct that is going to sit there until you ventilate and push air into it. All right? And just stop and think about it. I put a tube into you and walk away. Have I done anything for your rise and fall of the chest? So I still got to do positive pressure. So remember, those two things have to go hand in hand. Just like an OPA. If you put an OPA in somebody, what oxygen delivery device should you now use? BVM. Because once you take their tongue and you secure their airway with an OPA, you have to force air in and out. Putting a non-rebreather on somebody with an OPA will not work. It's like putting a non-rebreather over an ET tube. It won't work. All right? We still have to force air into them through positive pressure ventilation. Now, let's relate this to asthma. So we run an asthma attack, and you have this. You have respirations 28, heart rate 120, pulse ox 100%, and the end tidal 60. Is that early or late asthma? Why?
They still have plenty of oxygen saturation.
Okay. I would expect to see this on my capno. Shark fin. Remember, in asthma, in early stages, they can get air in. Every time we inhale, what gas is it? Oxygen. The problem in asthma is they can't blow the trash and CO2 out. That's why wheezing in early asthma, it's not heard on inhalation, it's heard on exhalation. Hey, will you crack that door a little bit?
So in later stages, you'll see pulse ox and end tidal kind of get closer.
You'll see the pulse ox go down. Here's something you need to understand. They should be able to suck air in. We should expect an asthma attack to have a normal pulse ox. How long does it take for somebody to go without air to drop their pulse ox? 6 to 10 minutes. So if I run on an asthma attack and their pulse ox is like 90, that should scare the crap out of you. Because that means that they're so constricted, they can't suck oxygen in anymore, and they've been like that for several minutes. Here's the other side of this. A pulse ox of 100 in an asthma attack versus a pulse ox of 90, which one is most likely albuterol going to work and why?
First one.
The first one, because they're still able to what? Inhale. And how do we give albuterol? Inhalation. Do not be one of these medics that walks out and just because the pulse ox is good, you think there's nothing wrong with your patient. I've seen it a lot, especially in our older guys over the years. They walk up and they're like, "You're fine. Pulse ox is 100%. You're breathing fine. See that? You're getting air. Calm down." No shit. Asthma has nothing to do with inhalation in the early stages. They can get air in, but they can't get the trash out. That's why they're what color in the early stages of asthma attack? And red. They're flushed because they have that acid and CO2 built up. They're dilated, trying to get rid of it. If an asthma attack is pale, it should scare the shit out of you. Because that means they're so constricted, they can't suck air in, and they've been like that for 6 to 10 minutes. This one, okay, you're wheezing. Let's get you some albuterol. Should work because you're still able to inhale and you're not hypoxic. This one, we need to get moving. We're going to have to be more aggressive. Now, when we do our treatments, per textbook, we are supposed to give albuterol by itself in the first treatment. All right? So we're going to give albuterol only. Albuterol is 2.5 milligrams in 3 mils of saline. Why do they want me to give it by itself?
Dry them out.
It's a rescue drug. Atrovent is not a rescue drug. Atrovent works on the parasympathetic. The parasympathetic is slow acting. The parasympathetic will dump and dilate and cause sludge. Salivation, lacrimation, urination, defecation, gastric evacuation. That's how like sarin gas and those things work. That's on the parasympathetic side. When you get an asthma attack, you end up getting a parasympathetic response where you end up with secretions in the bronchioles. Atrovent helps prevent those secretions and it blocks the parasympathetic, but it takes several minutes for that to occur. Albuterol, on the other hand, it's the rescue side of the drug. Atrovent is not a rescue side, it's a preventative side. If you've ever seen commercials for asthma, they say they'll, advertise Singulair, Advair, Combivent, all these things, and it will say not to be used as a what? Rescue inhaler. So let's use this back door. I have a Halligan and I have a wedge. All right. So my Halligan is the albuterol, my wedge is the Atrovent. So if this door is shut, all right, and I got my wedge here. This wedge is going to do me no good until the door is what? Open. So you take Atrovent and the door's already shut, you're achieving nothing. The goal is to take that albuterol, which is my Halligan, rip that door open, and then as it's starting to reclose, I get my second albuterol, and then I shove my Atrovent in there as a wedge to prevent reclosure. When you mix them the first time together, you're taking 3 milliliters of fluid from the Atrovent, 3 milliliters of fluid from the albuterol. Now you got 6 mils, they're going to have to be nebulized. So instead of getting albuterol and the rescue drug in 5 minutes to 7, 8 minutes, now it's going to take you a full 15 minutes because you double the amount of saline in that nebulizer. So we're doubling the amount of time it takes us to take that Halligan and get the door open. Does that kind of make sense? That's why per textbook and testing purposes, the first treatment is albuterol, and then once the albuterol wears off, the door's going to want to start to shut. So I give another albuterol to open it back up, but this one's mixed with Atrovent, whereas the albuterol is wearing off, the Atrovent's in place to prevent the complete closure. That's why Atrovent's a preventative drug, not a rescue drug. Does that kind of make sense? And it's all about volume.
So per registry, you do want to give Atrovent as well, right? I mean,
Only in the second and third treatment.
With no improvement.
So what I should do is I start here with albuterol, and then in the second and third treatment, I do albuterol plus Atrovent. After 3 treatments, I have to make a decision. Are they getting better or not? So let's say after 3 treatments, they're here. Respiratory rate's 24, heart rate's 112, pulse ox is still good, end tidal's down to 50. They getting better or worse? Better. So my albuterol and Atrovent's working, correct? So could I give them a 4th treatment? Sure. If I give them 3 treatments and I'm here, 32, 140, 92, and 70. After 3 treatments, they're not getting any better. So what drug should I give now? Not Solumedrol, not MAG, Epi. 3 treatments, no relief, Epi 0.3 milligrams, 1 to 1,000, sub-Q or IM. If Epi doesn't work in 5 minutes, you're going to have to look at hanging a MAG drip, because MAG will move the sodium potassium and relax the smooth muscles, and MAG is going to be over 10 to 20 minutes, 1 to 2 grams over 10 to 20 minutes because they're alive. Now, Solumedrol. Solumedrol is not a rescue drug. And what I mean by that is it's not going to work in the next 2 to 5 minutes after I give it. But it's a great drug. There is no rule on exactly when you should give Solumedrol. I could give this guy Solumedrol right here, and it may not work for 15 minutes. That's why it's not a rescue drug. It's a great drug to give, but it's not going to work in 90 seconds like what the Epi is. Does that kind of make sense? So when do I give Solumedrol? This is just my unwritten rule. All right? And I've had pretty good luck with it since we started carrying Solu-Medrol. Well, shit, I think the first time I carried it was late 90s. I run on you, and you're 19, 20, 21 years old, and your pulse ox is good, inside is a little high, and you're wheezing. You ran out of your inhaler yesterday afternoon, and at 10 o'clock today, you're going to go get your inhaler refilled at Walmart, Walgreens, whatever. You just need a little something to get you by. So I get on you. You have nice, loud wheezing. What is nice, loud wheezing? Tell me.
There's air moving.
They're moving good air. Even though they're wheezing, they're at least got volume. So more than likely, I'm going to get by with one treatment. And if one treatment works, you don't want to go to the hospital. Do I need to give you steroids then? No. Probably not. So I give you albuterol. You are cleared up pretty good. I will probably go ahead and give you another one with Atrovent, just to where you don't reclose prior to going and getting your meds. You don't want to go, that's fine. Document it, fill out your form, etc. He's not a candidate for Solu-Medrol. Versus I run on him. He's been out of his meds, trying to make it. His pulse ox is here, end title's up, and he's squeaking. If he's squeaking, he's not moving very much air. He's going to probably take more than 1 or 2 treatments, correct? And if he's going to take more than 1 or 2 treatments because of how bad he is, not because I'm trying to get him to Walmart, I'm going to be taking him to the hospital. And if you're going to take more than 1 treatment and I'm going to have to transport you, you're getting Solu-Medrol early. It may not work while we're in back of the ambulance, but 15 to 20 minutes from now, it may be the difference between that person having to be intubated and going home in a couple hours. Because if they end up having to be intubated, they're going to be in the hospital a few days. And so as a general rule of thumb, multiple treatments and transporting, the earlier we can give Solu-Medrol, the better. 1 treatment just to get them by till they can get their meds, don't need Solu-Medrol. You have that asthma attack that's at work, and it's payday Friday at noon, and they just kind of, I'm wheezing. I can't stay at work. Y'all know what I'm talking about.
I was about to try that.
Yeah. You know what I'm talking about. Especially in our district where we got all the call centers. Since COVID happened, nobody works. But payday Fridays, our station was the busiest in town. Payday Fridays from about 11 o'clock to the night shift. Because the only way they could go home from these giant call centers was, if you're so sick you need to leave, we don't want the liability of driving, so we're going to call an ambulance. That's the way it worked. So if it's one of them where you're like, okay, whatever, and you're just going to give them a treatment just to where it makes them feel better, but they're not really sick, don't need to give them Solu-Medrol. But if you think it's going to take multiple treatments and you're going to transport them, the earlier we give Solu-Medrol, the better off they're going to be. Just understand that for registry, if I've done 3 treatments and it's refractory, go to the epi. So what they're going to say is, 20-something-year-old male, female, flushed and red is because they're trapping carbon dioxide. 3 and asthma, and your asthma is refractory to albuterol and Atrovent, what should you try next? If it's refractory to albuterol and Atrovent, it means no improvement, we're going to epi. If it says you have an asthma attack or status asthmaticus means it's not responding to the albuterol, Atrovent, and epi. So what's next? Mag sulfate, 1 to 2 grams over 10 to 20 minutes. Yes, sir.
I didn't know you
get
mixed
mag
up
sulfate
albuterol
with
and Atrovent together. I thought it was just like after the albuterol didn't work, first people go to Atrovent.
No, the second and third you mix them.
Okay.
First one albuterol by itself, and then each one after that you mix them.
Would you be wrong with giving them the max amount of epi if you did hear like the wheezes like what you were talking about? Or do you need to?
You mean like
They usually put them together.
jump straight to it?
Yeah, just go straight to 0.3 instead of giving
So-
them 0.1, 0.1, 0.1. Do you need to go to that?
No,
max?
you start at 0.3.
Start at 0.3.
Yeah, if we've blown through 3 albuterol and we're going to epi, we're starting at 0.3.
So they need to get that epi
Yeah,
on board.
0.3, just like we would in anaphylaxis. It's the exact same thing.
So I've seen it come up on some of my testing apps or whatever. There's racemic epi too, right?
Yes.
And that's an inhaled medication.
So racemic is basically taking epi 1/1000 and putting it in a nebulizer with saline and then having them inhale it.
Okay.
That is mainly used for croup or what we call the regiotracheal bronchitis. The reason why racemic epi works is because of vasoconstriction, and in croup, in kids, they got the soft tissue swelling, so that vasoconstriction will help with croup. Racemic epi is usually for croup.
Okay.
So, asthma for registry, albuterol and Atrovent, 3 total albuterols, 2 of them had Atrovent mixed, no improvements, epi, no improvement, mag. Somewhere between albuterol and Atrovent and epi, you need to consider putting them on what? CPAP. CPAP. Try CPAP before we end up at epi. If they're really tight, the sooner you get them on CPAP, the better, because if they're too tight, they're squeaking, they're not going to breathe deep enough to break that 5 centimeters on the CPAP. If their volume is too low, CPAP's not going to work. So if you walk in and they got that look there, and then they're barely making eye contact, you better do CPAP now. And remember, you can run your albuterol and Atrovent through your CPAP. There's a T tree that will connect to the mask in the CPAP to where you can basically force that albuterol in. But if you wait too long, you're going to miss it. So if you walk in and they're already wanting to nod their head, you better get that CPAP now, because if not, they're going to be breathing too shallow and too sleepy to use that CPAP. The earlier the better.
Can you hit them with the epi right off the bat if you know you're gonna be going through all your
For
treatments?
testing,
No.
no. Real world,
Yeah.
yeah. So like, let's say that I walk in and you got somebody on a home nebulizer, and they are taking, you walk in and they got albuterol going, they got Atrovent, and they've been stacking treatments for several hours. They've already tried multiple on their own, and you walk in and they're doing this, and you barely hear, like when they go to breathe in, you're like, and you just hear it. Hit them with it. Hit them with it. You know, and just document, you know, patient not moving any air, severe inspiratory, expiratory wheezing, retraction, multiple home nebulizers, no relief. That's why we went straight to the epi. All right, just use caution if they have a history of heart disease, if it was like a 70-year-old. But yeah, hit them with it.
Will they ever give you a question to where, you know, they're giving signs and symptoms and it's heading down that road to where you're thinking before you even look at those answer choices that this person might need to be intubated or use a BVM? Will they give you answer choices that say BVM and like an ET tube or a King tube?
So you can't intubate, so you ventilate and pre-oxygenate.
Okay.
How do I know that? Because your adult ventilatory management skill sheet said, scene safe, BSI, open the airway, check for a gag, ventilate, pre-oxygenate, prepare equipment, and then the last step was intubate.
Okay.
The treatment order for the registry comes off your patient assessment medical skill sheet, your patient assessment trauma skill sheet, and your adult ventilatory management, aka intubation skill sheet. That's the order they're going to go through. So you can't intubate somebody unless you're ventilating. Now, if it said 27-year-old male refractory asthma, patient is being ventilated, what's next?
Innovation.
Intubate. But I can't intubate until I pre-oxygenate and ventilate. And think of it like this. When we did intubation skills testing in October, if I was to walk in the room, walk straight up to the mannequin, drop the tube and walk away, I would what? I would fail. So if that would make you fail the skill, that would make you fail the skill or fail the registry as well on the computer test. It's the same order. Now, if it says your patient's already being ventilated, what's next? Prepare Equipment and Innovator King 2. All right?
So some of the epi is sub-Q or IV?
IM.
I am.
Yeah. Yeah. Because they're already tachycardic from severe respiratory distress, we're going to try IM first. All right? So 3 treatments, no relief. Sub-Q epi or IM epi. That didn't work, MAG. Somewhere between the treatments of albuterol and epi, I should have tried CPAP and Solumedrol early. Just remember, Solumedrol and Atrovent are not rescue drugs per registry. Albuterol is. That's why we start with albuterol. Buterol and Atrovent. No improvement. Will they tolerate CPAP? Epi don't work. MAG. All right. So are we good on asthma? All right. Bronchitis, blue bloaters. Sick 3 months out of the year for 2 consecutive years or more. And they will usually have something greater than the 40 rule. The 40 rule is packs of cigarettes a day times years they've been smoking. So when you take a patient to the ER, especially in respiratory distress, have you noticed the nurses ask, do you smoke? And if the patient says yes, they say, how much and for how many years? What they're trying to figure out is if this person's packs a day times years is greater than 40. If the packs a day times years is greater than 40, they're at risk for COPD. The 2 diseases that are chronic obstructive pulmonary disease are chronic bronchitis and pulmonary emphysema. Chronic bronchitis is an infection 3 months out of the year for at least 2 consecutive years. They have rhonchi and wheezing. Remember, rhonchi is booger, snot, and phlegm. Wheezing is the high-pitched constriction. They have wheezing and rhonchi, usually will have a fever and a cough, and because they're always sick, they're not healthy, they don't exercise, because they got booger, snot, and phlegm, they can't get oxygen into the bronchioles. So a lot of times they'll have cyanotic fingernail beds that are blue, and they're fat and overweight, and they're bloated. So blue bloaters, bronchitis, all the B's go together. Treatment is the exact same as what we did at asthma. Albuterol, second and third, Atrovent, no relief, epi. Somewhere in there we need to be given steroids, and also give your asthma and bronchitis patients fluids. Why would I want to give asthma and bronchitis patients fluids? Breaks up the mucus, and it will help the Atrovent pull it out of the bronchioles easier. If you stop and think about it, if I was to take a thick substance and I put it on the table, and you take a paper towel to it, because of how thick it is, it's hard for that paper towel to pick up, right? But if I put a whole bunch of water on top of that thick substance and then took a wet paper towel, it's going to clean up easier because the water has thinned it out and changed the thickness of it, right? It's kind of like when you have a bunch of rock hard boogers in your nose. Well, if I change those boogers to a liquid snot, I can blow it out easier and I can clean that nose out easier because I've thinned the secretions. That's what fluid boluses do for my asthma and bronchitis patients. So, exact same treatment for bronchitis as we had for asthma. Albuterol and Atrovent, 3 treatments, no relief, consider epi. Somewhere between albuterol treatments and epi, I should have considered CPAP and Solumedrol and give them fluids to help thin the bronchial secretions to where they can cough it up and break it loose. The chronic bronchitis are not hypoxic driven yet. COPD, pulmonary emphysema patients are. The reason why pulmonary emphysema patients are hypoxic driven is because their alveoli have collapsed. Normally your bronchioles look like this, and it's got a nice balloon on the end of the alveolar. It's called your alveolar sac. What ends up happening in emphysema from all the years of smoking and nicotine is that sac has collapsed and deflated because it's lost its elasticity properties. So basically, instead of having a nice big balloon that allows oxygen and carbon dioxide through it, it's collapsed and inverted. So how are they going to reinflate that balloon? Well, if I gave you a balloon, would you inhale into it or would you exhale to blow it up?
Exhale.
You would exhale. So what they do is they trap carbon dioxide and they exhale into this alveoli and they keep it full of carbon dioxide. If they were to fully exhale, it would collapse their lungs. So they never fully exhale. As a result of never fully exhaling, they chronically keep carbon dioxide in their alveoli. That's what keeps that balloon inflated to where there's area for oxygen and carbon dioxide to move in and out. So in order to prevent full exhalation, they puff. The other thing they do is if you were to try to take a deep breath with your mouth wide open, now do it through pursed lips. Feel the difference in the pressure? By breathing through pursed lips, they're essentially CPAPing themselves to push air through the back pressure of carbon dioxide. Pursed lips, puffing to prevent full alveolar collapse. Now, because you're trapping all this CO2, the chemoreceptors in the brain detect high levels of CO2. So it's going to tell them to increase their respirations. So when they're first developing pulmonary emphysema, they're going to start breathing faster and faster. So every time I raise my hand, I want you to take a breath. Just nice. All right, breathe, 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 breathe. How you feel? A little lightheaded. You did that for about 10 seconds. Imagine breathing that fast every minute, every day, every hour for the rest of your life. Trying to get that carbon dioxide level down. How skinny would you be? You'd be pretty skinny. What would happen to your chest? It would become barrel. Because this carbon dioxide level is always elevated, too much CO2 is bad, that's going to make you vasodilate. That's why they are pink in appearance. Pink, puffers, pursed lips, pulmonary emphysema. As a result of them breathing that fast and never being able to fix their carbon dioxide levels, their brain gives up on regulating CO2. They no longer regulate their breathing based on carbon dioxide levels. They now will only breathe when their body detects mild hypoxia. This is what we call hypoxic drive. So now, in order for the chemoreceptors to detect a problem, because they've given up on trying to fix carbon dioxide because of how fast y'all were breathing, now what's going to happen is the brain has to detect mild hypoxia to remind them to breathe. So here's what I would expect to see in my hypoxic drive patient. I would expect a pulse ox between 88 and 94% and an end-tidal CO2 between 50 and 70. That is normal for them now. So what hypoxic drive does is if I take Mr. Robbins here, the brain goes, hey dude, your pulse ox is 90, take a breath. Hey, you're 90, take a breath. You're 90, take a breath. Oh, you're 100, fuck you, you don't need to breathe. That's knocking out his hypoxic drive. Because when there's no longer hypoxia detected in the chemoreceptors, the brain no longer reminds him to take a breath. So now instead of fighting for every breath, he's going to start to become sluggish and go to sleep. Because he has not had that much oxygen and had that easy of time breathing for years. That is what knocking out the hypoxic drive does. Now, in order to knock out the hypoxic drive, we have to be with them long enough to get their sats from hypoxia to 98 to 100% and then leave them like that for another 10 to 15 minutes. So it takes about 20 minutes of high flow oxygen to knock their hypoxic drive out.
Is it all the same chemoreceptors, like the aortic?
Yes.
And the carotid and central?
Yes, it's at the ones that measure carbon dioxide specifically for respiratory, though, are in the medulla.
Okay.
All right? So, that is knocking out the hypoxic drive. For us to knock out somebody's hypoxic drive, we usually have to have them on high flow oxygen 15 to 20 minutes. If you put somebody on a non-rebreather and they have emphysema and they have a pack rule above 40, that means that they've smoked more than a pack a day times years, and that number is above 40. That's usually when they start to develop hypoxic drive. And I'm only telling you that because sometimes they'll throw that in a question. 72-year-old female, severe shortness of breath, appears red. She has a 50 pack rule. All right? So that's telling me that for more than 40 years, she smoked a pack a day, which puts her at significant risk for emphysema and hypoxic drive. It's just another descriptor. So that's what that's telling me, yes.
Can you explain the pack rule? How are you getting that number? Because I'm a little confused.
Okay, so packs a day
Okay.
times years.
Okay.
So if she smoked 2 packs a day, 40 divided by 2, she would develop emphysema in 20 years. If she smoked a pack a day, it would take 40 years. If she smoked a pack and a half, we're about 25 to 30 years. And that's why that nurse goes, how much do you smoke? I smoke a pack a day. For how many years? Oh, since I was 18. Okay, you're 70. So that would be 1 times 52 years. That number is greater than 40, correct? So he's at risk for emphysema and hypoxic drive.
So he smoked a pack of cigarettes for 52 years.
Correct.
Okay.
So 1 times 52 is above the 40 rule, and that's where that comes in. Yeah.
So is it it's a progressive, you get bronchitis first and then,
Not
pulmonary
necessarily, but COPD as a whole, whether you're bronchitis or emphysema, it is a progression over time and years of smoking.
Okay. So if you have COPD, I think I've seen a question, you have both basically?
There's 2 sides of COPD. You have a bronchitis side and an emphysema side. Some can have both, some only have the emphysema side.
Okay.
So if I said you have a COPD patient with frequent respiratory infections, which side of COPD is that?
Bronchitis.
Chronic bronchitis. You have a COPD patient that is breathing through pursed lips and pink in appearance. Emphysema. That's what they're going to ask. And treatment for them is both the same. All right? They're both going to get albuterol, Atrovent, fluid, steroids. The difference is in the emphysema side, they're hypoxic drive driven.
Okay.
So we got to use a little bit more caution with our oxygen. Another thing to look at. Yes?
Yeah, but because, like you said, it takes a long time for it to convert, we don't really have to worry about it, I guess, on our end, right?
Correct. So let's do this. If the registry says the roads are snow and icy, the bridge is out, traffic is worse than normal, you have a long distance transfer, what does that do to my normal 15 minutes with that patient? Increases. And that's why they'll put those descriptors in the test question. All right? Like one of them used to be, you're transporting an elderly COPD patient to the hospital. Your ambulance breaks down on the side of the road and her respirations are starting to drop and she's becoming lethargic. Well, what have you done to her?
Washed her out.
You knocked out her hypoxic drive and now she's like, I have 100% and don't even got to try and breathe. Once we knock out their hypoxic drive and they have to be intubated, it is anywhere from 6 weeks to 6 months to wean them off the ventilator, because think about it. I'm trying to take you backwards from 100% and get you back to fighting for every breath and having a pulse ox of 88 to 94%. And that's why it knocks out their hypoxic drive.
So they legitimately cannot have 100% oxygen.
Not for long, because it will knock out their hypoxic drive. And there's a couple other things that play into that. First of all, we have to look at our hemoglobin. Hemoglobin is on red blood cells. Red blood cells are called erythrocytes. The red blood cell carries oxygen on one side and carbon dioxide on the other. That's why it's called carboxyhemoglobin. Well, if she's not able to, or he's not able to have enough oxygen to transport, all of the peripheral cells are going to go from aerobic to anaerobic metabolism, which is going to produce more carbon dioxide and trash. That excess production of trash is going to cause them to vasodilate, which puts all the red warm blood beneath their skin. That's why they're red in appearance. They will also, because they have so much diminished oxygen, they will increase the red blood cell production, and that is called polycythemia. Polycythemia is increased red blood cell production to where they can transport all this trash they're generating and try and help them move a little bit more oxygen. So they end up with increased red blood cells. So the combination of the red blood cells and the vasodilation is why they're red in appearance, or pink. Which is why we walk in, they'll be tripoding, be pink, and they're puffing through pursed lips. Pink puffers, pursed lips, pulmonary emphysema. Now, how do we know if that oxygen level is normal for them or not?
Ask them.
They're probably not going to know. So here's what we look at. And you can't ask a question on a test. Who are you going to ask?
How are they presenting?
Yeah.
How are they presenting? What do you mean by that?
Are they working to breathe? Are they,
In 30-second shifts.
they working to breathe? Are they perfusing well? Are they using accessory muscles?
What if I gave you this?
Club fingers.
What if I gave you 62-year-old female, she's on a nasal cannula, 4 liters per minute, heart rate 96, respirations 20, pulse ox 90, end tidal CO2 50. Is that normal for her or not?
Probably not. That was a little high.
Is her heart rate above 100?
No.
Is her respiratory rate above 20?
No.
Is her pulse ox in the 88 to 94%? Is the end tidal between 50 and 70? That is normal for her. She doesn't need any more oxygen. Treat her while we're there. What if I said nasal cannula, 4 liters per minute, heart rate 112, respiratory rate 26, pulse ox 90, and end tidal 60? Is her heart rate up?
Yeah.
Is her respirations up?
Yeah.
So even though her pulse ox and capno's fine, this is more hypoxic than she's used to. So what should we do with her cannula? Raise it. Bump it up to 6. So you see, by looking at heart rate and respiratory rate, that will help us determine, is this more hypoxic for her than normal? All right, let me check, see what Larry is real quick.
Yellow. Oh, dude. That girl's gonna be fucked.
Nate, watch your head.
A little bit to the left.
Yeah. All right, nasal cannula, 4 liters, heart rate 130, respirations 32, pulse ox 84%, end tidal 70. Non-rebreather. Non-rebreather. Now, do I want to leave them on the non-rebreather the whole time?
No.
If I get this, I put them on a non-rebreather, and I get this. What am I knocking out?
Hypoxic drive.
I am real close to knocking out their hypoxic drive. You see how they're getting so low, everything's coming down? What would happen if I did this? Put them on non-rebreather, a couple minutes goes by, and they're 102, 26, 92, and 55. What should you do with that non-rebreather?
Turn it down a little
Take
bit.
it off. I got him out of that danger zone where they were in severe respiratory distress. Take it off and see how they do now. All right? I don't want to overflood them. All right? I do not want to overflood them. Because if you overflood them, you're at risk for knocking out their hypoxic drive. So that non-rebreather, if a cannula is not keeping them in the 88 to 94 range, then what I want to do is I want to put them on a non-rebreather, get them from the 70s or 80s into this range, and then take it off and put them back on a cannula and see how we do. If I take it off and I put it back on a cannula and they fall back down in the 80s, we'll put the non-rebreather back on. And we may end up having a teeter-totter between a non-rebreather and a cannula. I put you on a non-rebreather, I get you 94%, heart rate moves back towards 100, let's take it off. Couple minutes go by, you're back down in the low 80s, heart rate goes back up, let's put it back on. Because I don't want to overflood them, because I don't want to knock out their hypoxic drive. Does that kind of make sense? Yes.
What are reassessment times? Like, I understand with this person, you would be every minute asking them how they're doing or whatever.
Per textbook, so per textbook, reassessing vitals, which is a complete set in a critical patient, is every 5 minutes. When you have a respiratory distress, it's supposed to be continuous pulse ox and continuous capnography. And what that means is I can look at the monitor continually and see where pulse ox and capno is at. So you want to look for answers that say like continuous SpO2, which is saturation pulse oximeter, or PETCO2 PETCO, which is peripheral end-tidal carbon dioxide, which is our end-tidal. But look for the word continuous waveform, continuous SpO2. That means basically we're leaving it on them the whole time we're transporting to where we're constantly looking at those numbers.
Okay.
What would be appropriate?
Go ahead. Blood pressure is every 5 minutes.
So is that based off of stable, unstable? The critical?
Yes. So a critical patient that we're giving meds and transporting lights and sirens is every 5. A rec check, nothing wrong with them, is usually every 15. Initial set of vital signs, a set 15 minutes later, and then a set upon their arrival at the hospital. If your transport time's less than 15 minutes and it's a stable patient rec check, you should have at least 2 sets of vitals, an initial and then one when you arrived at the hospital.
Okay.
The minimum on every patient is 2 sets of vitals, even on refusals. That is the minimum, 2 sets of vitals. That way you can show what they were when you got there, and when you left them at home or left them at the hospital, you need to get 2 sets of vitals on every patient.
Okay.
All right?
What would be appropriate as far as liters per minute on the patient with the non-rebreather?
12 to 15. That's all you can do because that's the skill sheet.
Are you going to run it on the lower end? I mean, you're not going to.
Usually it's going to say 12 to 15.
Okay, just regardless.
Yeah, and a lot of that's going to depend on what your oxygen tree is. Like our oxygen trees in our ambulance go 10, 15. There is no 12. I don't want to refill it. So, do we understand the hypoxic drive and the difference between it and people that breathe on CO2? How does everybody in this room, what makes us breathe? Carbon dioxide. Why?
Take it out.
Receptors when it gets high.
Why? Why though? Why do we all work on carbon dioxide?
We have to get rid of it.
Why?
Because too much of it's bad.
But why is our body set on carbon dioxide, not oxygen?
Because there's more of it. Negative feedback.
It's the feedback loop. In order, stop and think about this. Carbon dioxide is produced at the cells, correct? In order to produce 35 to 45 parts of carbon dioxide, you have to have a normal heart, you have to have a clear upper airway to bring oxygen in, you have to have a clear lower airway to move it to the lungs, you have to have enough blood to dissolve the oxygen into the lungs, you have to have blood vessels intact and not letting the blood leak out, and you have to have a good enough pressure to force that blood to the capillaries to move it into the cell, and then you have to have enough oxygen and sugar to create metabolism. If any one of those things change in that equation, it will change the amount of acid being produced. If I was hypoxic driven only, I could never detect DKA. I could never detect metabolic acidosis. I could never detect a heart attack. I could never detect blood loss because I would only detect if my oxygen level fell, which would take 6 to 10 minutes and would have to be an airway issue. Carbon dioxide is related to all things that keep me alive. And that's why it's part of that feedback. That's why in the heart attack yesterday, despite clear breath sounds, despite a clear upper airway, despite a pulse ox of 100%, they got short of breath, not because they needed oxygen, but because their heart was producing what? Acid and carbon dioxide that they had to breathe off. That's why our body is set on carbon dioxide, because it's the end-all be-all of all parts metabolism. That kind of makes sense? So that's the rationale or the reason our chemoreceptors are set on carbon dioxide initially. Imagine if you had emphysema and DKA. Well, they really wouldn't be able to have Kussmaul's, because in Kussmaul's they have full exhalation to eliminate the carbon dioxide and waste. So now you got a puffer who would in order to eliminate the waste, they would have to go, which would collapse their alveoli. That's why emphysema patients, if they have comorbidities, start stacking up on their death rates. Because now they can't compensate for the renal failure because they can't blow off the acid. They can't compensate for the DKA. And that's why they typically will end up dying of something unrelated to the emphysema. Another problem is developed in the body because they couldn't compensate for it. All right? Are we good on treatment on them? What is it called when they increase red blood cell production to transport the carbon dioxide?
Polycythemia.
Polycythemia. What is the hemoglobin dissolved in? Where's the hemoglobin found out? What's it transported on?
Red blood cells.
Red blood cells. What's the actual name of a red blood cell?
Erythrocyte.
Erythrocyte. Pneumonia occurs in one lobe. Usually they'll have a fever and yellow or green productive cough. Now, classic pneumonia occurs in people that are healthy adults. All right? However, the pneumonia that we're probably going to see is in people that live in what facilities? Nursing homes. And because they're in a nursing home, they're bed confined. Because they're bed confined, they lay flat in bed. So what type of pneumonia do they have compared to a 20-year-old? Bilateral in both lobes. You or I, because we're upright, can move around, that pneumonia infection is typically going to stay in one lobe. In nursing home patient, because they're laying flat, that booger, snot, and phlegm usually ends up in multiple lobes, so they have bilateral pneumonia. So it's going to sound like crap. Well, what's the difference between booger, snot, and phlegm sounding like crap and rels that sounds like bubbling crap? Most CHF patients, because they always have fluid in their lungs, will also develop pneumonia. CHF required CPAP, nitromorphine, and Lasix. If you give Lasix to a pneumonia patient, you increase their chances of death by about 40%. So how do I tell without a chest x-ray, which is what they'll do at the ER, how do I tell the difference between pneumonia and CHF in back of the ambulance? Temp. Okay. If they got a fever, that's usually pneumonia. If they got a fever or sepsis related to it, what will their pressure be? Lower than normal because of vasodilation. If it's CHF, what will their pressure be? High. And what rhythm will they typically be in? AFib. And what would their skin tint be? Cool, pale, clammy. CHF gets cool, pale, clammy skin because they don't have enough cardiac output. So remember, they released epi. That's why they got the AFib. That's why they're cool, pale, clammy. So crappy breath sounds, hypertension, cool, pale, clammy, AFib, most likely CHF. Crappy breath sounds, fever, lower than normal blood pressure because of vasodilation, pneumonia. Fluids in albuterol, don't necessarily need to give them Atrovent because it can dry up. the secretions. We don't want them dried up. We want them thin to where they can cough them up because it's in the lung, not in the alveoli. So fluids, albuterol, transport. Definitively, pneumonia is going to need an antibiotic to kill the infection. All right, does that make sense? Top of page 3. Respiratory distress on the bottom of page 3 into the top, or I'm sorry, bottom of page 5 into the top of page 6. Respiratory distress is like compensated shock, okay? Yesterday in compensated shock, blood pressure was still good, heart rate and respiratory rate went up. All right, it should be the bottom of page 5 to the top of page 6, depending on how it printed. All right, respiratory distress. Respiratory distress is basically like compensated shock. They tell you they can't breathe, heart rate's up, respiratory rate's up, and they're compensating for the shortness of breath. That's respiratory distress. All right, Josh Sheets having a hard time.
And then it goes into like foreign
Okay,
body.
this right here is respiratory distress. I don't know. Where's the respiratory distress?
Yeah.
There's a couple different, shock factors.
It went to the bar early.
Okay, well, write it. After pneumonia, oh, I see what happened. All right, that's all right. Respiratory. So let's do this. Besides respiratory failure, you got respiratory failure on your page below hyperventilation?
Yeah.
So besides respiratory failure, put versus respiratory distress. We'll just clean it up and do this. So respiratory distress is like compensated shock. Heart rate's up, respiratory rate's up. They can tell you they can't breathe. Respiratory distress is going to be managed with oxygen and the appropriate medication. So if they're asthma, wheezing, pneumonia, bronchitis, emphysema, we're going to be doing albuterol. All right? So respiratory distress, they can tell you they can't breathe. We're going to put them on oxygen and we're going to give them the appropriate med. It's like compensated shock. Everything's up. Respiratory failure is like decompensated shock. Everything's down. Heart rate's down, respiratory rate's down, level of consciousness is down. So this person has a respiratory rate below 12. So a lot of times you'll see them with a rate of 6. Heart rate will be Brady. Pulse ox is dropping. End tidal's dropping because they're not moving any air out, so there is no end tidal. If they don't exhale, there's no end tidal. So everything is dropping in respiratory failure. So think of it as respiratory distress. They can tell you they can't breathe. Everything's up like compensated shock. Respiratory failure, everything's down like decompensated shock. If they go into respiratory failure, you need to immediately positive pressure ventilate. And if you do not immediately positive pressure ventilate, then we need to prepare to intubate because they're going to go into respiratory arrest. So, respiratory distress, everything's up. I tell you I can't breathe. Respiratory failure, decreased level of consciousness, everything is circling the drain. If I do not positive pressure respiratory failure, they will go into respiratory arrest where they are no longer breathing. After 4 to 6 minutes of respiratory arrest, they will go into cardiac arrest. So, I can't breathe. I tell you that, I'm distressed. I'm altered and bradycardic. I'm in failure. I quit breathing. I'm in arrest. Positive pressure ventilation is the treatment for failure and arrest, followed by intubation. Respiratory distress is oxygen and meds. See the difference?
Yeah. You said 4 to 6 minutes in respiratory arrest causes
Well,
cardiac arrest.
Correct.
In a respiratory failure, this is not going to be a CPAP.
No, in respiratory
PVM.
failure,
No.
they're too altered and the breathing is too shallow and slow to use CPAP. All right? So somewhere between distress and them crashing is when we should have put that CPAP on, which if you think back to what we drew earlier, somewhere between a non-rebreather and bagging is when we should use CPAP. When they go respiratory failure, we've missed our CPAP opportunity. All right? Foreign body aspiration, y'all should have that one. Back below pneumonia. Basically, if they're coughing or choking, abdominal thrust, back blows. If they become unresponsive, start chest compressions. After 30 chest compressions, look in the airway and clear it. After 30 compressions, if you don't see the object, reposition the airway, the head, try to force air in. If we can see the object, we'll grab it, but we are not doing blind finger sweeps because it can push it deeper. All right, so 30 compressions, look at the airway, try to give 2 breaths. If that doesn't work, reposition, air still won't go in, back to 30 compressions. If they've already coughed the object up, humidified oxygen to help with the soft tissue swelling. If y'all have ever choked and your throat gets scratched, humidified oxygen. How do we make humidified oxygen back of our ambulance? Saline into a nebulizer and just let them inhale it. All right? And you can run your nebulizer through a simple face mask or through your mouthpiece.
Will we see J thrust on the chest or behind the J?
No, they'll usually call it abdominal thrust or back blows.
Okay.
All right? Or they'll just come out and say Heimlich, but abdominal thrust and Heimlich. They will ask you sometimes about doing Heimlich maneuver on an obese or pregnant female. And if you do that, it goes over the center of the chest instead of the abdomen. So if you can't get your arms around the abdomen where she's pregnant, you're going to come behind it and go center of the chest.
If we choke on things, there's a couple questions on this. I see them choking. Do I have to ask them, are you choking?
Yes.
Yes.
And if they're moving air, we're going to encourage them to cough.
Before I start abdominal.
Correct.
But if they are not moving.
If they're not moving air and they can't cough, then we'll do abdominal thrust or back blows, and then when they become unconscious, we'll do chest compressions.
Yes.
So, are you choking? Yeah. Try and cough it up. You choking? Nothing? Abdominal thrust, back blows, Heimlich, unconscious, chest pain. Chest compressions, I mean. We already covered hyperventilation. We covered that earlier with psychogenic shock or panic attacks. Remember, it's respiratory alkalosis. Slow their breathing down. Worst case scenario, if it's horrible, sedate them. Paratonsillar abscess is a distractor for epiglottitis. Epiglottitis is in toddlers, and it's fever, sore throat, drooling, leaning forward. If I said you have a 32-year-old female, fever, sore throat, drooling, leaning forward with foul-smelling breath, that's a paratonsillar abscess. It's an infection on top of the tonsil. It can create difficulty swallowing and difficulty breathing. Humidified oxygen is all we can do for them. What they're going to have to do at the ER is they're going to have to go in and lance it, drain it, and give them antibiotics and steroids. And it smells pretty bad. All right? So that's just a distractor for epiglottitis. Any questions over the airway? All right, let's take 10 minutes, come back in. Let's come back in at 35 after so I can deal with that next class for a few minutes. So 35 after, we'll get started back.
Yeah, we had a